We're back to the Neil Haley Show. And my guest today is the author of The Corona Protocol, Three Secrets to Success, Paul Corona. Paul, thanks for stopping by. And you never knew, you thought Corona, you would always be known after Corona, the beer. And then the virus came. How
Yep.
are you?
A lot of teasing about the virus, that's for sure. And yeah, thanks for having me on. I appreciate
What
it.
about the beer? Did you have teasing
Here,
about the
yeah,
beer too?
yeah, absolutely.
Yeah, but thank goodness when they
Sure.
went from coronavirus to COVID, that was
Yeah,
probably your best thing that happened to you.
yeah,
So,
exactly.
all right. So, in a brief summary, what are the three secrets to success? And I'm all ears, and I'm gonna enjoy this conversation more than ever because, that's the thing. We all, if especially if we have that mindset that we want to succeed, we really want to figure out these success principles and what defines it.
Well, the three secret. My last two books. I've written six books. My last two books are actually training manuals for doctors. So what I want to do with the Corona Protocol, Three Secrets of Success, and then the Corona Protocol Prescriber's Guide is my last one, is basically just going kind of teaching doctors my method of doing things. And my method has been many years in the making about how I've learned to do what I do and to create what I call the Corona Protocol. So the three secrets, I've written about this in other books too, but number one is understanding the mind-body connection. And this is something that I learned back in the 90s when I first started doing this. There's a powerful link between stress and the body. For example, stress causing headaches, neck and shoulder tension, stomach problems, back, so there's a lot of like pain and physical, we call somatic symptoms associated with stress and mood. So for doctors to understand that and treat that properly, because most doctors don't. The second is for understanding the the full spectrum of bipolar disorder. People misunderstand the disorder. They think about it as with when it comes to like bipolar one, where you have mania and irrational and paranoid and all that. That's bipolar one. But the majority of bipolar disorder is not that at all. It's just mostly depression that's just not getting better with antidepressants. Um, and then doctors have to learn to step back and say, wait a minute, I gotta diagnose this more properly because obviously the treatment the treatment's not working for what I'm assuming the diagnosis is. So it's for doctors to relook at that diagnosis and the number three rule is for doctors is to get people into what we call remission, which means completely well. And completely well means back to my old self again. I haven't felt this way in years. Or, frankly, doctor, I don't think I've ever felt this good, to tell the truth. I didn't even realize that someone could even feel that way. So, what I'm looking for is a feeling of normality, not a drug feeling, not a mind control, and nothing like what people think it is. It's just basically getting people back to where they were. If once, and then most people tell me that place is usually either early childhood, when there's not a lot of worries in the world, or late teens, early 20s, when college or career, so it's those are what people tell me is probably the happiest times in life, and so the key is getting people back to that happy place that they used to be at.
And when do you think people are most, you say there's a specific time period when people are the happiest? Is that true? Or, I mean, I guess when we're younger, not now, not now. Yeah. I mean, because I'm the happiest I've ever been in my life at
Good. So
53. So
yeah,
there's no way I would ever trade where I'm at now
right.
for the past.
Right, exactly. So that means you're fine. But there's people at your age and who say, I haven't felt good for 20, 30 years. I really haven't felt good since my 20s or maybe, so that's what I mean. That means that person needs to get back to where they were and that's where medications come in and we could talk about that, but medications are basically rebalancing a person's neurochemistry to try to get them back to that normality, and that's all the medications are about is rebalancing the nervous system.
See, I find this fascinating because ultimately, mind body, such a powerful thing. Because ultimately, if you mental health wise aren't feeling good, your body's not going to feel good. And if your
Exactly.
body's not feeling good, your mind isn't going to feel good. You're not going to feel confident. You're not going to feel the specific things. So it can relate so much to each other, and we don't put enough time into either to keep healthy.
Right. Yeah, my first three books took me 12 years to write. Is called Healing the Mind and Body. They call it the trilogy, one, two, three. But yeah, my first three books are all about this whole subject of mind body, and how powerful that really is, and how unrecognized it is by people, by doctors. They don't understand. They just think it's if they can't see it on a blood test, or if they can't diagnose it the way that doctors usually diagnose things, then they don't feel comfortable treating it, or they don't think it's real, or they think it's just people making stuff up. I don't know what, but the majority of people who have these issues are continue to suffer and have no end in sight. That's the
Yeah.
hard reality of it.
And that's the sad part in so many ways.
Yeah.
Because you're like, really? Oh my, because I mean, that's so important. So why does treatment often fall short for patients? You talked about this before. For example, why aren't band-aid solutions acceptable in your opinion? I know that's
Well, because again, if I focus on just the symptom, like, oh, you have insomnia, here's a sleeping pill, rather than, well, what's causing the insomnia? Let's get to the
right.
bottom, let's get to the root cause. Or I have body aches and pains, here's an opiate or here's an anti-inflammatory. Well, why don't we get to the root of what's causing the pain? And so, yeah, the Band-Aid solutions are just, like the Xanax and Valium, they're just covering a symptom, but not getting to the root of what's causing the symptom. So that's where my technique is different is, and I, again, I came to a lot of this on my own, especially when I started doing this in the early 90s, understanding that doctors weren't doing things right. For example, every doctor thinks, except me, the SSRIs are the best first line agents, Zoloft, Lexapro, Prozac. I disagree. I think they're not best first line agents because they don't help with the physical symptoms we were just talking about, and their side effects, and so. And then there's the oh well you got to wait because it'll take 4 to 6 to 8 weeks for it to work. That's nonsense. No medication I work with takes that long. It takes maybe a week to two at the most. So those are just two just very basic rules of psychiatry and mental health that are completely wrong. And it's just a matter. Also, what I do is I work quickly. I put and I often will put medications together, which is common in my practice, maybe 2 to 3 medications at once to get people really to that great place. But most doctors don't know how to do that. They don't know how to add something, when to add it. So a lot of this really I read a lot of books. I started as a family doctor in the early 90s, and what drove me to this over the following decade was just my interest in the subject, trying to research what's going on here. How come I'm seeing results that I'm not reading about? And that led to my finally starting to write because I was so frustrated with, the fact that just doctors aren't getting it and patients aren't understanding. And so that's what started me on the writing process to try to change that.
So how can we get doctors to really think of the patient in a way and not just go straight to medication, not go straight to a certain thing before looking at all the other things? You have a lot of functionality in your mindset.
They read my books. That's how. Uh, yeah, I mean, yeah, you got to learn more. You got to educate. It's a matter about our education, and not just doctors. A lot of the providers now, physician assistants, we call PAs, nurse practitioners, we call NPs.
Right.
So there's a lot of prescribers out there that aren't doctors, but so my books are really intended for them, for primary care doctors. And again, primary care doctors, we get some of this in training, but not a lot. And then most primary care doctors in practice just don't feel comfortable treating it beyond an SSRI. Oh, here's some Zoloft or Lexapro. And if that doesn't work, they punt and they go, oh, go to a psychiatrist because I don't know what to do. So I basically telling doctors, here's what you do, here's how you do it. My books are very nut and bolt, like, trying to really understand the details of how I make decisions, when to add something else, when to stop something and try something different. So when my goal is results with no side effects.
Yeah.
So many on my social media, the feed and whatever, like it's a lot of criticism about you're a drug pusher and you're a shill for big pharma.
Exactly.
You're a drug pusher. You're the, you know, they be, people don't understand this subject very much, and they think it's terrible, and they think it's just you have to just go to counseling and do therapy and then get exercise and you're gonna be fine. Just stop, worrying and just, So a lot of people discount how people are feeling, and because they're not that person, and they feel, well, it worked for me. Hey, I just do cardio and it works for me, and well, yeah, great. Exercise works for a lot of people. I do it every day, but it doesn't fix the neurochemical problem if that's the issue. And the reason that the chemical problem happens to begin with is genetics. It runs in families, so you can't help it. You can't help what is handed down to you.
Yeah.
Um,
So this is where medications, and I'm looking at, because you're definitely giving me a real good piece of this, and that's why you have to read the book. But ultimately, you're not knocking medications
oh
like
no,
some people do, where the we talked about, you connect a lot of the functionality, but certain people need to be on medication. It just has to be the right medications. And
right.
it really, are we diagnosing the problem correctly, Paul? That's
Not
the thing.
not usually. And yes, I'm very pro medication, and because medications are it's kind of like a diabetic trying to like an insulin dependent diabetic trying to treat it with diet and exercise. It's not going to work. It's a medical thing. You have to do the insulin, or else you're going to probably lose your life. Well, this is just as medical as that, but so that's where medications come in, and yes, their medications are amazing, and they just all they do is get people feeling back to themselves again. That's it. That's all I'm going for. But there's, and we get a lot of criticism about potential side effects. Well, again, so if you get side effects, we stop it, or I add something else to get rid of the side
Right.
effect. It's just a protocol I go through with people, and it's highly successful. I get pretty much everybody completely better within maybe 2 to 3 visits at the most,
Wow.
which takes like a month or two.
So you're
And
really identifying if that medication is the right medication for them. And let's kind of talk about that, because I've
yeah,
had medications I've been on, I'm like, oh no, I'm not doing it again. I'm out. A weekend, or it's just not
yeah,
working. No,
right,
thank you. I'm trying something different. Give an
right,
example. I had one time with a higher blood pressure I had, they gave me one with a diuretic, and it was horrible. It made
yeah,
side effects way worse. I
right,
said, I'm getting off this. I'd rather not be on it. Then they got me on a smaller one and it was perfect.
yeah.
We don't have those. That's where you want to educate those people. We don't have those conversations between the provider who prescribes that medication and the patient. And you want to teach and develop it to say, hey, this is what you need to do so these medications are going to be successful. How much time period do you give people till you say I got to take them off that med? It's not working.
Quickly, I mean, if it's not working, I know that within a week or two. Let's say, for example, it's an SSRI,
You need
and
to find what an SSRI. I'm just, for our listeners that might not know. I don't. So
so SSRI is selective serotonin reuptake inhibitor. So basically, it's the most basic medication, like Lexapro, Zoloft, or the most known of them, and Prozac. But they basically balance serotonin, and the problem with them, they can help, but then people say I feel apathetic, I feel flat, I have sexual side effects, I'm tired. Okay, well, but if they say my anxiety is gone, I feel way better when it's certain things. Okay, if it's that simple, I might just add some Wellbutrin, and the Wellbutrin will boost their energy and motivation, get rid of the side effects, and they're doing great. Or if I feel like the results are substandard and they're getting the side effects, I stop it and the side effects go away. And then I learn, okay, well, let me try this thing instead. So it's a matter of, it's a little trial and error to figure it out. But I figure things out pretty quickly, and I move quickly. Most doctors don't do that. They move very slowly. Patients forever to get in. They don't return phone calls. So for me, I return every phone call every day. I do a lot of in between visit advice that I don't cover, that I don't charge for, and I just do a lot of, because I want to get people better quickly and safely, and it's totally achievable. And I do it. I mean, I hardly ever have a patient that I can't get better. It's extremely rare.
really interesting. So, what do you think it is? It's because you truly are focused on that patient, and you talk about the mind body connection. That's key, because if you're getting sick on this med, it's not going to help your mind,
Right.
and vice versa. So, I'm understanding that. And what do you think's different that every healthcare provider needs to do once they put someone on? We're going to only talk about psychiatric meds, right? We're not talking about every type of medication, right, Paul?
Right,
Because more you're more involved on that side of the
right,
than versus blood pressure medications or inhibitors. You're looking at more of the psychiatric meds and how they're just uh, diagnosed or put on the wrong things before
right,
looking at everything.
right, right. I'm sorry, but
Yeah, so I'm kind of asking, how do you kind of figure that out when a patient comes in?
it's all history. I mean, with what I do, it's not blood tests. There's no scanning. There's no brain scans. It's all by history, and that already makes sometimes some doctors and patients a little hesitant. They go, "Well, how do you know?" It's like, "Well, I know by talking to you. I know by listening to you. I know by taking a good history. So by taking all the information about that person, I mean, I go back to the beginning. Tell me about your childhood. Tell me about middle school and high school. Tell me about your 20s. Tell me about." So I basically go through the person's whole past and get an idea, like what diagnosis we're dealing with based on really taking a lot of information, and then this trial and error. I call it rational trial and error. It's not just throwing darts at a dartboard. There's actually a reason, specific reason I'm choosing whatever I'm choosing, and I try it, and if it works, great, I was right. If it doesn't, or if it, let's say it worked, but then gets side effects, I go, okay, well, I'm close, but it's not, so okay, let's switch to this one and see if I can get the positive effect without the side effects. Great. And now, how are we doing otherwise? Do I need to add something else now? So it's just it's a process, but it all has to do with listening to people. And doctors are great at talking, but we're not great listeners because we want to rush through things and here, just take this and just without really sitting down and really getting to know the person and their and what and everything they're dealing with, the physical problems they're having. So I want to know everything. I get a whole about their blood pressure, diabetes, whatever. I get a whole
Yeah.
history about all their medical issues, and to make the decision because I don't have the blood test to go by, but I do have the information from the person.
What I think that the reason why your mission is this book and for practitioners and everyone to read it and also patients is the fact is you want more and more people to act like you do at your practice. That's how I would want. I want them to look at history. I want them to spend more time. I want them to ask more questions. I want more sifting questions to understand the patient before, hey, you meet, you talk once, and then you put them and say, here's your medication schedule. That's it. And not ask the questions regarding how that medication's working. What progress are we seeing? If I put you on a specific medication
Right.
and you're not seeing progress in 3 months, then it's not working.
No, then that's wrong. There's not progress in 3 months, progress within a week or two.
Oh, really? Okay.
So now that again, this is where doctors go wrong because they think that way. They think, well, we'll give this medication a few months, and no, no, no. If it doesn't work within a week or two, it's not going to work in 3 months. If it doesn't work right away, and doctors also have to titrate. They can't just like put them on a pediatric
Yeah,
dose. Okay,
yeah. Titrating's
few
very
months
hard.
later, I'll go a little bit higher in the dose. No, no, no. You got to just hit it and go for it. And that's what doctors don't do. And another basic rule is that SNRI. So they're the medications that work on serotonin and norepinephrine are better than SSRIs. And I'm the only doctor I've ever heard to say that that's the case. And I learned that like 33 years ago when the
What
first
medications would you say would those be?
Pristique is my favorite. Effexor XR, Cymbalta. So these are basically better medications overall. They do more, they're less side effects.
What about Effexor versus Clonopin?
Well,
What are your
Klonopin,
thoughts?
again, the Klonopin's a Band-Aid. So we're talking about a benzo. So the Klonopin is just when you're having an anxiety attack. So I want to prevent the anxiety attacks. Do I prescribe things like Klonopin? Yeah, I do. But they're really reserved for like panic attacks. But
Oh, not constantly taking it all the time.
no. And that's the problem. If people look at that, as, oh, I just take it every day. Why do you take it every day? I don't know. I just take it to prevent anxiety from happening. Okay, well, now there's an addiction potential for here going on. But now, no, let's get to the root. And instead of just covering up a symptom, let's get rid of the symptom. And and so that's where I work on is trying to get the Klonopin use down, and work on, really what's causing the anxiety.
What about titrating for Effexor? Is that good or bad in your opinion?
Very good.
Very
Yeah,
good. Okay.
very
Okay.
good. Yeah,
Good.
and if it's not good, I stop it. I mean, it's not for everybody. No medication is for everybody. Um, and Yeah, and the book that really led to these two books was the book before it. It's a crazy title. It's called The Corona Protocol: A Scientifically Proven Medical Solution to Stop Addiction, Bullying, Homelessness, School Shootings, and Suicide. 30 years in the making. So the book that I wrote before these two is really for everybody, not just doctors.
Wow.
But there's like 30 case studies. I talk about the cases. I talk about the treatments. So if someone wants to see in real life what I'm doing on the individual patient, read that book. I think these two books, patients might like them, but they might get kind of bored with them because they're very medical. The one before it, the Corona Protocol book, which is sold thousands. That book is really I think the key book of the six I've written.
Oh, so is it different than Secret Success? That's your newest one. So what's the difference? So give me the
Yeah,
line of them. Which
the
ones?
the
Yeah.
the, well, the three secret success and the prescriber's guide are the last two. Those are the training manuals. But before that was the book I just said, the Corona Protocol book with that long subtitle. Um, and then after I wrote that book, and I said, now I need to write books for doctors. I need to tell doctors how to do this protocol now, and that I've created really, and because this protocol I've never read any other doctor that does it this way. Even in I've read psychiatric books and none of them help me, and so that's why I decided to write my own books.
Got it. See, and this is smart, but I'm already intrigued by this. So I'm going to go to some. If I had you on another podcast, I'd want to because of your knowledge base. It's phenomenal, and it's stuff that they're not talking about. Creating those clips, putting that stuff out there on a medication point, because everyone wants to try to take people off medications before figuring out if that's the right thing to do. Answer
Right.
that question for me. The people just quick cold turkey. We make do a tie trade. We get them off. And the reason is because that person really didn't want to be on it, or we thought, well, this is the best thing we should do without really having the data to prove it.
Well, but again, you got to work with individual patients. So if someone's on, like, say, Klonopin and has been on for a while, you can't just stop it abruptly
No,
because
you can't because there's a lot of bad things that happen, right?
yeah, you can have a seizure, you can have, so yeah, so it's a process. So what I try to do is like just say, let's do this, let's go down little by little on the Klonopin. Let's see if we can get you down to a minimal dose or even off of it based on when if I'm treating the underlying cause and it gets better, then you're not going to need the Klonopin. Or you have it for emergency basis on hand, but you don't take it every day. You just take it here and there when you really need it, like flying or public speaking or whatever it is that people's fears are. That's they can come in handy for those things.
Interesting. Okay. So this question is definitely one that you wanted me to ask today, and this is a really interesting one. It says, how do you determine whether or not someone is bipolar?
All history, completely history. And so the easy ones to diagnose is bipolar one, which again is the irrational paranoia. They're not sleeping. That's mania, and then they often crash into depression, and so it's a very up and down disorder. They're high, they're low, they're high, they're low. Um, Bipolar two disorder, but see, bipolar one is only 10% of bipolar, and bipolar two is 20%, which is not the high mania, but like we call hypomania, which is maybe they're sleeping 3 or 4 hours at night and they
Oh,
sleep and they feel great the next day. But it only lasts for so long. They can't ride that wave too long before they crash. And 70% is no mania, no hype. It's just depression. And how do you tell is bipolar depression? Because they're not responding the way that they should respond with antidepressants.
mm,
Or antidepressants get them. I try this. I try adding two things together like I usually do. I'll add two antidepressants together, and if that isn't getting people better, then there's something else going on. Or if it makes them worse, if antidepressants make them worse, then that's a definite key that they're bipolar. Or if they're getting suicidal ideation on, that's a definite that we're dealing with bipolar. So that the whole confusion about suicide medications is a misdiagnosis because the suicides with medications happen with bipolar patients typically, not regular depression or regular anxiety.
what about when you go to PTSD, chronic PTSD? Where do you put them in that environment with meds?
Well, I mean, I've seen patients. I still have patients from the Korean War, the Vietnam War. They're 70s and 80s. And so I treat a lot of PTSD, and these people have gone through a lot of trauma, and sometimes it's very satisfying. Sometimes I see them 50 years later, and I get them better, and they said I haven't felt this good literally in 50 years, and that's just so satisfying to me with these people who've given so much to our country. And so yeah, PTSD is very treatable. It's just we need to kind of rebalance
Is
the trauma.
medication, which medications do you feel work the best with PTSD? It
Well,
depends.
again, with PTSD, it's pretty much like everything else. It depends on is it unipolar, which is not, or bipolar. So is it, how do you approach treatment? Is really based on the history and history, and then you if you're right about it when you see the response to medications. Is it a positive response? Good. Is it a negative response? Okay, let's take that away and let's reassess. So did I just choose the wrong medication? Did I choose the wrong? Is it the wrong
Mm.
diagnosis? And so yeah, it just takes a lot of experience doing it, which I've done this for what, 33 years now.
You're very knowledgeable. See, I've not known much about, I don't take any psychiatric meds, but
Yeah.
I know of people who do. And that's why I'm asking these questions because it's very important, especially when we see the number of women who are put on these medications during menopause. And is this always the right thing? Are we
Mhm.
treating it and no one's looking at the history? So, what would your recommendation as a patient that is on some sort of psychiatric meds? What would you recommend if they're not doing the kind of questions you're asking right now? When you have in your practice, are you just medication or are you also therapy?
No, just medication. I work with therapists, but my role is really medications, the medical part of it.
Okay. So you don't talk to the patients except their history.
Well,
Not
I mean,
that's
there's a lot of talking to people because I get to know them very well. I get to know a lot about them, their personal history, their family history. So yeah, I mean, I'm friendly with them. So a lot of people even say, "Oh, you're better than my therapist." Well, I'm not. That's not what I'm here for. But what my job is a lot of listening and giving advice, and so that's kind of what therapists do. But again, I separate that. That's not my job, and
no, but you
I'm
seem very, very good. If people are in your area, they got to go see you. Unless you have a huge waiting
well,
list, I can tell you
and
really are not.
I see a lot of people out of state, so I can't do controlled substances out of state, but I do have a lot of patients out of state, so that's not restricted,
Oh, really? Hmm.
yeah. So a lot of people on, phone visits, Zoom, things like that.
Really? So, but not insurance, straight cash pay, right? If it's out
Yeah,
of state.
yeah.
Mhm.
Unless it's a Medicare PPO, then that's what we take. But yeah, everything else is cash.
But it's a great way for the really identify if the what you're doing with medications is the right thing because a lot of times
Right.
you're going to use your health insurance and it's garbage and it's not the
True.
fault. That's why you're here to educate them. That's why
Yeah.
you're the expert because
Right.
you put so much time to this, not just into your practice, but you
Mhm.
put time in writing these books. So the research, what you've seen, is right there with all the books. So list all your books because you're such a wealth of knowledge, Dr. Corona. So go ahead.
What about the books?
Yeah, all your books for people.
Yeah, yeah. Again, so the first three are Healing the Mind and Body, the trilogy. So I just released a second edition. So especially the first two books are really good for patients. The third book are for patients and doctors. Um, the Corona Protocol, the long subtitle one. If you're going to read one book, that's probably the one because it gives a lot of examples of treatment strategies and it's also something that sometimes I think patients can probably read these things and then educate the doctors or maybe bring it into the doctor or maybe buy the doctors my last two books and say here, can you do this, and maybe force the doctor to try to learn these things, and if they're not learning, move on to someone else, because if you're not getting the results and you're just getting side effects and the doctors know what they're doing and they don't have an answer,
Mhm.
you can't just go keep going back. They don't know what
Right.
they're doing. You got to find someone who knows what they're doing.
All right. Well, fantastic. Best, you have a website too?
Yeah. Doctor, so like DR for doctor, Dr. Paul Corona, MD.com. I have all six books on there. My TV show,
Oh,
and
cool.
the Corona Protocol, the one I just said with the long subtitle, that's on Audible. They're all on ebook. They're all on soft cover, hardcover. My
Mm.
TV show is on Roku, Amazon Fire, and YouTube. It's called The Dr. Paul Show.
We'd love to put that on Radiate Television. I'm going to be out in California in September for the Radiate Film Festival, and
Oh,
we have a streaming television network,
oh yeah,
and we'd love to have your show on it. So
yeah, yeah.
I will talk to. I already have something where we're already gonna have this relationship, and it's gonna be with somebody else. But I'll let you know. So we'll
Okay,
definitely need to check all that out. I appreciate it. Thanks
yeah.
again, Dr. Paul. All right,
Thank you.
that
Thanks
was
for
a
having me on.
special. Yeah,
Appreciate
good.
it.
All right, that was the Neil Haley